Welcome to Health Stealth Radio, where we move away from the mundane to gather insights from the shadows of enterprise and patient cybersecurity. Yes, we surely believe that traditional themes like endpoint software and zero trust are critical, but given massive advances in AI, remote and wearable device hacking, and data hostage negotiators, there's a much darker side to cybersecurity, and not everyone is quite willing to talk about it in public. Health Stealth Radio will thrive on these topics and encourage fireside spats to debate them. Here's your host, Frank Cutitta.
So good morning, good afternoon, good evening, wherever you are. This is Frank Cutitta. I'd like to welcome you to the latest episode of Health Stealth Radio. There are a few things that I've been involved in personally. This is actually, as Surabhi knows, this is my 5-year anniversary of having COVID. And I was one of the first COVID patients in Massachusetts. I'm not saying this is a sob story because here I sit right now. Largely related to the good efforts of the people like my friend here on the screen. But I did get to experience it from the inside. I looked at it as 5 years of primary research, the first of which was from my bed for 100 days and in a coma for a part of that. But I did learn a lot as a healthcare journalist and researcher about the patient experience from that stay. That I never could have gotten. So it was the worst of worlds, and it was the best of worlds from a research point of view. So one of the things I've learned is through an organization called the PFAC, which many of you in the audience might know, and everybody has a different acronym or name for it in their organizations. But I sort of had a battlefield promotion when I was in Spaulding to be anointed to be a member of the PFAC at Spaulding and eventually became co-chair, which I'm honored to do. But one of my colleagues is on that committee and one of the leaders of that committee is here with me today. And the reason that I'm bringing this up, and I'm sorry for the long-winded intro because I really want to get Surabhi to speak about the whole program. There are certain things that you have in a healthcare organization, as you well know, as information technology folks, that are seemingly very simple, especially as we started rolling out telemedicine. We had iPads all over the place. So, oh my God, this is simple. One of the things that we'll talk about in this episode is how even the most simple things of, in this case, a welcome video for patients and family members can gather complexities that we didn't normally think of and add to that other politics and economics of healthcare as it is right now, as we're going through not only at Mass General, Spaulding, and other institutions around the country and the world economically, how from where you start these programs to where they end up to reach success can be incredibly challenging and yet incredibly exhilarating when you get the end result. So without further ado, I'd like to have Surabhi introduce herself, talk a little bit about her role, and then sort of we'll get into the mechanics of why I'm even doing this episode and why it seems simple, and then what the challenges are. Please, Surabhi.
Thank you, Frank. I'm honored and excited to be here. Well, I am a physical therapist by profession and currently work as a manager for quality, safety, compliance, and patient-family relations at Spaulding Hospital for continuing medical care, which is located in Cambridge, Massachusetts. It's a long-term acute care hospital which specializes in complex medical and rehab care for patients with higher medical acuity, which usually requires an extended length of stay in the hospitals, typically around 1 or more months, depending on individual condition and progress. The only new thing is that since November of 2024, we opened a new 30-bed inpatient facility. It's not a facility, it's a unit that meets the need of patients requiring intensive rehab alongside complex medical and nursing care, where the average length of stay ranges from 3 to 4 weeks, again, depending on individual recovery and goals of progress.
How do we get to where we are right now in terms of this project, the video project? What was the genesis? How was it incubated? And then you either inherited or volunteered, depending on where it is in an organization. Tell us a little bit about the genesis.
It all began with I am graduating with Masters in Healthcare Quality and Safety from Harvard Medical School in May of this year, which is exciting. And the project was part of my capstone project. The idea is to utilize a 7-step model for quality improvement framework to look at the problems at hand and just do a deeper dive of what exactly is the problem at hand. You have to clarify what are we trying to address. So in search of a capstone project, what started as a quest to develop an app that could interpret voice messages left by patients, families, or caregivers who speak languages other than English ultimately evolved as a process to bridge the communication and access to information gap for patients, families, and caregivers arriving here at Spaulding, Cambridge. And the whole crux was that it was impacting their experience of care, as well as it was impacting staff satisfaction. Problem was that in fiscal year 2024, 50% of the complaints, concerns, or grievances that we retrieved from our internal safety reporting systems were stemming from communication issues, as well as unmet patient family expectations, which were revolving around mostly they did not know what to expect after they arrived or after they were admitted to Spaulding Hospital, Cambridge. It's not a very rare occurrence. It's a very common problem. So that was a good starting point for me. And then we did an extensive current state analysis, looked at the data. We looked at patient interview findings. We talked to staff. We did review. I mean, when I say we, I said me, I looked at the existing process. What do we have in place that is done to orient the new patients, families, and caregivers that are coming through the door, and identified an opportunity to improvise our current admission process to address issues related to communication and unmet expectations. Patients often arrive at long-term acute care hospitals with very limited understanding of our service capabilities or frequency of services, et cetera, which leads to unmet expectations. And as a result, our frontline staff frequently encounters very emotionally charged interactions, contributing to stress, emotional burnout. And no matter how hard they try to rebuild that trust, it often results in very limited success in service recovery efforts. So talking about transition of care, it's very widely recognized as the most vulnerable point in our healthcare continuum, which is when patient is moving from one care setting to another. And the data or the literature finding was very not too surprising. About 80% or more preventable adverse events have been linked to communication breakdowns during transition of care, usually between clinicians or even between clinicians and patients. Every organization has put in a lot of efforts to bridge that gap in communication to mitigate the risk of errors that leads to potential significant physical harm. Mm-hmm. However, very inconsistent efforts have been made to improve communication with the patients, families, caregivers who have a very critical role in their own care that can prevent the errors that actually lead to emotional harm. So we have a lot work done for physical harm risk mitigation, but not so much for emotional harm.
So it's sort of interesting from the patient perspective, how I got into this whole thing, that healthcare organizations create the illusion that they're already doing this kind of welcome thing for new patients. In my case, I didn't find the welcome. It wasn't even a welcome book. It was sort of like a user's manual until I had to get something when I was being discharged out of a cabinet that was next to my bed. And there was a little binder in there that theoretically somebody that came in with a lot of distress and in some cases inability to have cognitive skills was supposed to read or to have their family read. And we know in the way that people consume and digest content these days, reading it from a binder next to your bed is not the way that it typically goes. So the next move in the world of digital transformation and digital health is that we look for other ways of doing that. How did this move forward? What was the next step? You did your sort of academic findings and literature, and then we move it into a real life situation. How did
I actually found literature that specifically said that like written or verbal and a video-based communication strategies in patient, family, and caregivers' preferred languages have been proven to facilitate better understanding of care and adaptation to transition of care. And I jumped with joy because I was like, this is good news, because before I transitioned into the role a year before that, based on the valuable feedback from our PFAC committee member, the video was developed, right? And I was instrumental at the very last stage of like developing a QR code and having that video posted on YouTube channel for Spaulding Hospital, Cambridge. However, the rollout was not as effective. And so I can't take any credit for the video because that credit goes to our PFAC committee members and the previous quality manager and our social workers who are very, very sort of instrumental in getting that done. I only came in because the rollout needed to be streamlined, because even though every step of the process was done in terms of developing the video, the rollout rendered it largely underutilized. So that's how I came in. I said, well, we have a resource, which is a phenomenal resource. It's a video-based communication tool known to be effective. What can I do to streamline that process and integrate that resource as a part of the admissions process so that patients arriving to our facility or their loved ones or their caregivers have access to that video within the 24 to 48 hours, which is, again, very vulnerable point for patients who are transitioning from one care to another. They don't know what their role is going to be in a different setting. They don't know what to expect. They obviously have this heightened sense of anxiety and stress because they don't know what is their role in this big scheme of things with change in settings. And it would be perfect fit if we can sort of give them a little synopsis of what do we have here to offer, what to expect in the next few hours of admission.
So at the onset, I mean, we got this video technology. It's very typical that people are using this every day of the week on their phone or on their desktop or tablet. How wide a net did you have to cast in terms of stakeholders? Then there's the other collaborators. How would you describe that group? I think the trendy way of saying is, how many pizzas would you have to order in a conference room to feed the people that were part of the collaborative group?
Frank, my list of stakeholders was exhaustive because one thing that I learned through my academics in terms of healthcare quality and safety is that you have to have stakeholders engaged from the inception of the idea, and it could be different stakeholders at different stages of your project, and all the way till you are looking at data, and then you turn around and share the data findings with those stakeholders who have been invested in your process. So it was start from the senior nursing leadership to bedside staff. PFAC committee had a big role in my stakeholder list. Patient experience committee members were a big part of my stakeholder list. Marketing and infection control, you name it, those departments. And I'm apologize for people I'm missing, but I have to say that all of these members were engaged at various stages of this project, beginning from identifying the risk to clarifying the problem. And then co-designing of the targeted intervention came in when we did multiple brainstorming sessions and then used our impact effort analysis tool to narrow down the interventions that would fit perfectly well with the process flow of our target users. And that would be like high impact but low effort. And I think this collaborative approach was really instrumental in having some buy-in from every stakeholder that was part of this initiative, and then securing approval for necessary resources. And the most important part was because they were so involved from the beginning till finish, I was sort of targeting for good anchorage of this whole initiative in the long term, because oftentimes that's a pitfall for any improvement initiatives. Now, that being said, the IT department was an absolute critical stakeholder. Because they were very helpful in getting, first of all, getting approval and allotting iPads that were basically the crux for my project.
Were they incremental iPads that they had to order?
Yep. Okay. The CIO knew about this project from the very beginning. I had approached him multiple times, basically explained him why What's the problem? What's the aim? And I actually got the approval and allocation of iPads within 10 days of approaching.
Mhm.
And that was
Considering the
when
number of beds that you have in the facility, how many units are we talking about that needed to be
we are
procured?
just talking about 5
That's
iPads.
all? Okay. All right.
The reason being is this is only so we are not going to get every unit will get maybe 2 at the most 3
Mhm.
admissions every day.
Right. And they're
So we
shared over and over. Yeah.
Right. And we had to exclude the inpatient rehab unit because the content of the video is very tailored towards the long-term acute care services. And the unit was developed well after the video was developed. So I had to see what resources we have and where is it more applicable. So I was focusing this project to be rolled out on 5 long-term acute care units. I got approval for 6 iPads. One was a backup. And then the department actually helped to configure the iPads so that you could just bring the QR scanner code down and that would link the video directly, minimizing any other steps. So it was a very quick setup, making the process very efficient and lean and less time consuming for the staff who was going to set up the video for the patients. So they were really, I mean, they were part of the stakeholder, and then they were really critical part of my implementation stage. Because if I didn't have their support, this project would have been sitting somewhere in a nice binder. So kudos to my IT department for doing that.
And whether I've got a few questions. One stemming back, I don't want to lose it, that you talked about infectious disease, people being involved in it. Is that because of touching the units?
And also the QR codes that attached to my POP it had to be laminated.
Ah, really?
Infection control was also involved because in the long run, we are thinking, can we have laminated stickers on all bedside tables for patients so that patients can just access the QR code once they know from their own smart devices, and then we can still wipe down the table, not leaving any risks for infection.
Interesting. So these are things that I just think I give them an iPad and they go at it and get it back, that we get other stakeholders.
It's a two-way approach because not everybody has a smartphone or a device. So we have to be prepared. Like if a patient comes in and who doesn't have access or there's, limited understanding, we have our equipment to go and set it up without putting any stress on the patients to worry about it. But we do also get the age range is so wide, like some of our patients are very young patient population and they're very good with their smart devices and they just pop it out and they watch the video on their own. Yep.
So you know how infatuated I am with the word co-design. So I mean I say that about our PFAC, that we need to be part of the co-design process. And you, as you mentioned very well, that the PFAC was, what other fingerprints were there, bad term when you talk about the tablet technology, what other aspects were there of co-design where people gave you advice that, you just said, we could have gone on the wrong way if we didn't have that. And the other part two of the question is, how much did the IT department have to come into for technical support or things like that? What are the number of instances of tickets?
Not at all.
Not at all.
Once they set it up, that's why I was like, we tried to make this process as simple as possible. And that was the big goal for the co-designing of interventions. Any new initiative, if it creates any other diversions from the current process flow, right away that it's going to fall through after you move on as a quality leader. If I move on to the next project, that project is not happening because it's a new added level to the existing process flow. So
it's essentially like the phones that people my age get now, where it's only all you have to do is press the buttons and talk on it. There's the usability issues are largely eliminated.
Keeping it simple really worked. And that was the big outcome from co-designing, because that helped me understand what was the primary player's workflow, existing workflow, and how can we just slide this process in without creating any waves or any other diversion from what is needed to be done on the part of my staff.
So you just came up with the other key word that we live by in healthcare is workflow. The other one that goes hand in hand, and again, I'm not trying to lead the witness, is buy-in. Thank you so much for adding another thing to my workflow today. Even though we dummied it down about as far as it could go. What what are some of those issues in terms of getting the stakeholders that were right there that had to deliver the product, so to speak, and then to get them to continue to do it and without digressing from their other work?
So getting in, I always find that if person who's going to be the end user or the champion of the process should know what's going on from the day the problem was identified.
Mm-hmm.
And they were, and when I say they, it's the clinical nurse leaders who
okay, that's
primary
important.
players.
It's important. Okay.
And I know we have talked about it in our PFAC meeting, but I really had to advocate to identify who's going to be the primary player and the secondary player, because quality is not a linear process. You always have to have a plan B in mind, because given the fact that we're in a very dynamic healthcare environment, things can go, wrong very fast. What if there's a medical emergency and the clinical nurse leader is busy with that, and now we have a patient who's nearing the 48-hour window? How do we manage that? Or if the clinical nurse practice leaders have to go on vacation or they're out sick, what do you do when that happens in that timeline? So with even before we started the training, I had to make sure that we had players identified for implementing this process, because I firmly believe that when a process is considered everyone's responsibility, it often ends up being no one's responsibility, especially if it is in the very benign or the beginning stages of the rollout. You're using technology to enhance your work, to support your work, but you still have to have some level of human interaction and touch. Primary players of this project were the clinical practice leaders, and the secondary players were the unit coordinators in case the CPLs or the clinical practice leaders were unavailable to set up the patient. Things can go wrong or in the wrong direction very quickly in a healthcare environment, so you always have to be ready who's going to be the next person if the primary person is not available to run the show.
So one of the greatest challenges on implementations like this is you go through the period of euphoria, okay, high fives, we have a success party, and then maintaining it on an ongoing basis. Did you ever find that there was, after everybody got into it, that there was any slippage, or was there momentum that was maintained?
First off, we had a major reorganization in our MGB network. So we did lose the team who was the primary players.
And how far along was that into the deployment?
1 month, 10 days.
Oh, no.
Yeah. But I was like, okay, I just lost a team of clinical practice leaders who were also our resource nurse. What do I do? So I reached out to the ACNO. I said, tell me, what do I do now? So she was the one who directed me, saying, you got to talk to the volunteer coordinator and see if we have someone who can just keep this project going, because a lot of time and effort has gone into that. And it worked. I have volunteers on Monday, Tuesday, Wednesday, and Friday. And we are still working to see if I can have someone come in on a Thursday to do it. And even though it's not a permanent fix, because, students graduate and they leave, but at least for now, we have to keep working with what we have. Again, quality improvement is not a linear process. That's my mantra. Like, you have to keep looking for what's your plan B to keep the project going.
And how about just when you look at patient satisfaction scores, are you able to do a cross-section of where that's gone that could be attributed to them knowing a little bit more when they got in than they knew?
So I just ran the reports for my own capstone, and I was looking at the number of scores 3 or above. Following the rollout, 100%. I interviewed 32 patient surveys were completed. All 32 patients reported 3 or above for the question related to the video. Like they understood what to expect, or they had the information of what to expect. So that was a huge success. The problem is the data set is very small. It was a very short-lived, for now, because right now we're trying to, once this process is even more ingrained with the volunteers, then we can go back and collect more data. But once the project halted, so I just collected data till February 10th, essentially. Up until that time, since the rollout on January 1st, the numbers look really positive. But I have to sort of think with a little grain of salt, like, it was a short-lived project. So I have to make sure that it's a sustained change. So far, the control charts are telling a very promising story that it is a stable change, but I still need to have more data over the period of time to understand if it was actually anchored into the point where, you're seeing a sustained change.
That's interesting.
Overall scores.
In winding down, I mean, one of the words that is always used in things like this, especially in an organization as complex as your own in terms of the whole network, is the word scalability. So I mean, obviously, you're this incubator, this little pocket that's put this on in a controlled setting. Are you getting any sense of other places? I'm sure you've been very open about talking about this project within the organization. I know that I've heard parts of it myself. If it's reached me, it's had to reach other people. How are you seeing scalability there? And are you seeing anything yet on variances in terms of how you've done it versus how other people might do it?
I was asked why are we not doing a channel in patient's room on a TV? When I did that option on my impact effort analysis, it was requiring a lot of effort to change the whole facility configuration of having a channel. And then the biggest problem was that then it is up to the patient's discretion. You can't really make it a part of your admission process. When the reorg happened, I was already exploring the options of maybe the liaisons at our acute care facility could share the link of that video with the prospective or potential patients, families, and caregivers. And people feel differently because they're like, there's already too much information thrown at us in an acute care setting. We don't want an additional video to be watched, which is fine. But if you want to watch, you have that option. And if you don't end up watching and you're here at our facility, that's our safety net. Then we do it over here. Okay, that's the redundancy. But it's still work in progress. I have met with the director of business and marketing, and she is helping. She likes the idea, but it's still work in progress.
Well, this has been absolutely great. It's thrilling for me as a patient member of the PFAC, and I just really want to thank you for your time. I want to thank you for the diligent work that you do. Very impressive, and I hope you tune into Health Stealth Radio to our audience for upcoming episodes. And thank you for joining us here today for this video case study.
Thank you for joining us today in the shadows for this episode of Health Stealth Radio with Frank Cutitta. If you like the program, please be sure to share your comments on our social media sites, or feel free to contact us with suggestions for new and stealthy show themes. We look forward to welcoming you again for our next broadcast. In the meantime, stay safe out there.